How's it going, guys? So this is a very baseline, pass level question for internal medicine for 2CK. If you're studying for step one, this is a difficult question. But for 2CK, no fucking excuses. You need to know this question. So before we get started, I will be an asshole like I usually am and tell you to subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. And find me on Instagram at Mehlman_medical, MEHLMAN_medical. The link is down below. And find me on Telegram. Recently created a Telegram group and channel. The links are down below. Now let's start the fucking question here where 65-year-old woman. She has a 1-year history of generalized fatigue, no significant past medical history. Laboratory studies are as follows. Hemoglobin normal at 14 grams per deciliter. Normal range is 13 to 17.5 for non-menstruating women and men. 12 to 17.5 in menstruating women. MCV is elevated at 108. Normal range is 80 to 100. A lot we can talk about, but you should know that B9, B12 deficiency, as well as alcoholism, very fucking high yield. Those are the top 3 causes of elevated MCV on USMLE. But you can get an elevated mean corpuscular volume in bone marrow disorders, okay? So you should have that also on the back burner for differential diagnoses. Serum calcium is normal at 9.3. Normal range is 8.4 to 10.2 milligrams per deciliter. Serum kappa light chains, very fucking elevated, okay? And ESR is normal. A bone marrow biopsy shows 11% plasma cells, which confirms the diagnosis of multiple myeloma. So as I said, this isn't meant to be a difficult diagnosis, okay? We're handing you the diagnosis here, and then we're going to ask you some answer choices. But multiple myeloma is a monoclonal expansion of plasma cells. It's a cancer of plasma cells of the bone marrow. Plasma cells, if under 10%, on biopsy, it's called MGUS, monoclonal gammopathy of undetermined significance, 10% borderline, often called smoldering myeloma, and then we progress into overt multiple myeloma if biopsy shows greater than 10%. And patients can have a spectrum of findings. They don't always have to have hypercalcemia with lytic lesions. They don't always have to have elevated ESR with the rouleau formation, which here it's a little bit weird, right? Because if the kappa light chains are floating around, you'd think they'd stick to the RBCs. The RBCs would precipitate faster. But my point is that you can get a spectrum of findings in USMLE, but this bone marrow biopsy, nevertheless, confirms our diagnosis. You need to know the first step in diagnosis for multiple myeloma on USMLE is serum protein electrophoresis, not hemoglobin electrophoresis, serum protein electrophoresis, which they already did here, showing the increased kappa chains. And then our bone marrow biopsy confirmed 11% plasma cells. So we're just going to look at the answer choices here. As I said, this can be a lengthy discussion, but we're not going to make this a 19-minute clip. Patients at greatest risk for which of the following? Shingles, wrong fucking answer, okay? AKA herpes zoster, caused by VZV. It's not to say that immunodeficiency wouldn't occur in multiple myeloma. There is going to be an increased risk / propensity for infections, yes. However, more likely to be bacterial because antibodies, the abnormal light chains coming from B cells were affecting humoral immunity, not cell-mediated immunity. But nevertheless, you do need to know for family medicine that the shingles vaccine is given at age 60, okay? Let's just continue through. S3 heart sound, wrong fucking answer. This on USMLE, this is synonymous with systolic dysfunction, okay? Dilated heart. Left heart failure at a minimum, okay? It can be congestive heart failure if you add right heart failure on top of it. Yes, it can occur in endurance athletes with high preload. Yes, it can occur in pregnancy, but we're talking overall, just S3 is systolic dysfunction on USMLE. In multiple myeloma, in contrast, the kappa light chains, these are proteins, immunoglobulins are proteins. They're floating around, they're going to deposit in the heart to cause cardiac amyloidosis. It's a very fucking high yield, you know, that you can get cardiac amyloidosis in multiple myeloma. That causes restrictive cardiomyopathy, a stiff left ventricle, an S4 heart sound, okay? Preserved ejection fraction. So very different. Let's just keep moving through, stay concise here. Renal calculi, wrong fucking answer, but not crazy, okay? Not a crazy answer. We have normal calcium here. Patient could go on to get lytic lesions and hypercalcemia and hypercalciuria, which could increase the risk for renal calculi. Sure, it's not outrageous, but it's not what the patient's at greatest risk for developing, and I'll explain in a moment. Pancreatitis, wrong fucking answer. No relation to this question, just a random distractor, okay? I mean, you think about alcoholism, gallstones that precipitate, that track into the biliary tree, choledocholithiasis causing gallstone pancreatitis, hyperlipidemia, right? Triglyceridemia, hypercalcemia. So yes, we can talk a lot about pancreatitis, but it's the wrong fucking answer. So nephrotic syndrome is our correct answer. As I talked about with multiple myeloma being a very high yield cause of cardiac amyloidosis, you need to know it can also cause renal amyloidosis. Okay, multiple myeloma. This is the sentence I want you to memorize. Multiple myeloma is the most common cause of renal amyloidosis. So you know how you get Bence-Jones proteinuria, right? So the immunoglobulin light chains, they fly through the urine and they're detected as the Bence-Jones proteins. Well, they also deposit in the renal parenchyma. And the proteins depositing where they shouldn't be depositing is called amyloidosis. So it's a nephrotic syndrome, okay? Renal amyloidosis in the setting of multiple myeloma. Very fucking high yield. So choice A, medullary thyroid carcinoma, wrong answer. I mean, obviously this is part of MEN 2A and MEN 2B. Okay, so medullary thyroid carcinoma, pheochromocytoma for both of those, but then you throw for MEN 2A, parathyroid adenoma or diffuse foregland hyperplasia for 2B, mucosal neuromas, marfanoid body habitus. Wrong fucking answer, as I just said. So look, we could make this an extended clip as I prefaced with, but we got to stay somewhat concise for the YouTube here. You know the deal, guys. I'll continue to make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.